I'm Dr. Fakir Robari, and this is urinary tract infections in adults. The basics are so important. Urinary tract infection is the most common bacterial infection in the ambulatory care setting in the United States. Nearly half of females will develop a UTI in their lifetime, with 25% recurrence within 6 months. And over half of all recurrent UTIs are caused by the same initial bacterial strain that caused the first infection. Pyelonephritis is much less common than cystitis, even in patients with untreated cystitis or untreated asymptomatic bacteriuria. Risk factors for UTIs include sexual intercourse, use of spermicides, previous UTI, a new sex partner, and a history of UTI in a first-degree female, because there are some genetic components into it. Now let's take a look at the anatomy of the urinary tract. So on the left you're looking at the urinary anatomy of the females, and on the right you're looking at the urinary anatomy of the males. Note that urethra is what's connected to the bladder, so the urine will actually exit the bladder through urethra in both females and males. So there's urethra that goes through the penis and is connected to the bladder, and the ureters connects the bladder to the kidneys in both female and males. Now in females specifically, the urethra is very close to the rectum. It's very easy for bacterial translocation from the GI. So the GI, so gastrointestinal organisms, can easily translocate to the urethra and then go up to the bladder. So cystitis is much more common in females compared to males. In males, you can see that the opening of the urethra is much further from the rectum. So it's much more difficult for translocation of bacteria from the rectum all the way to the urethra. Also look at the anatomy. So it's much more difficult for bacteria to travel up the urethra in the males. So therefore urinary tract infections are more common in females compared to male. Another thing to note is that in females, when females get urinary tract infections, the bacteria can oftentimes colonize the vagina, and in males, if males get UTIs, the bacteria can also colonize the prostate. So the prostate is also involved oftentimes when a man gets a urinary tract infection. And in men, the bacteria can also cause infection of the urethra. So urethritis is possible, as well as epididymitis. So epididymis is this area that's connected through the prostate to the same pathway. In general, urinary tract infections are divided into two categories: the upper urinary tract infections, which is primarily pyelonephritis. Pyelonephritis is the infection of the kidneys, and the lower urinary tract infection, which includes cystitis, epididymitis, prostatitis, urethritis. So the bottom three are specifically in men, and cystitis can happen in men and women. Let's take a look at the pathogenesis of urinary tract infection. So as I explained on the previous slide, is that bacteria can oftentimes translocate from the gut, specifically from the rectum, and go through the urethra. And then once they go through the urethra, they can colonize the urine in the bladder. This can cause inflammation and an immune response, specifically neutrophils, which can cause epithelial damage, leading to the burning sensation in the bladder. Now for most people, this would be the end and their infection will be resolved. However, for some people, the bacteria can ascend even further. So through the ureters, the bacteria can actually ascend all the way up to the kidneys, and they can actually colonize the kidney tissue, resulting in inflammation and damage to the kidney. There are a lot of vasculature in the nephrons, so the bacteria can easily get into the blood, and that could lead to bacteremia or infection in the blood. In general, there are 3 ways to get urinary tract infection. The first way to get urinary tract infection is through the ascending pathway, which I just described, with the bacteria translocating from the gut to the urethra and ascending to the bladder and then to the kidneys and eventually to the blood. Another way is if the bacteria actually come from the blood. So if somebody has bloodstream infection, because the blood goes through the kidneys, the bacteria can actually go from the blood to the kidneys and then from the kidneys to the bladder, causing cystitis. And the third way of getting urinary tract infection is actually through the lymphatic system. The lymphatic pathway is not as common. In fact, the evidence for it is actually from animal studies. Now let's take a look at reliable resources. IDSA is the Infectious Diseases Society of America. It's the organization in the United States that develops clinical practice guidelines for infectious diseases. The first guideline that you should be aware of is the 2009 IDSA guidelines for catheter-associated urinary tract infections in adults. This is the guideline that clinicians typically refer to for complicated UTIs. The second guideline is the 2010 IDSA guidelines for acute uncomplicated cystitis and pyelonephritis in women. The third one is the 2016 IDSA guidelines for candidiasis. This guideline includes recommendations for candiduria, which is the urinary infection caused by candida, which are fungal infections. You will learn about fungal infections on a different topic. In 2019, IDSA released guidelines for asymptomatic bacteriuria, and most recently in 2025, they released guidelines for complicated urinary tract infections that includes pyelonephritis. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antibiotics used for UTIs. Let's take a look at some anti-infective agents that are commonly used for the management of UTI. Historically, fluoroquinolones have been frequently used for UTIs. So ciprofloxacin is one of the commonly used fluoroquinolones. The mechanism of action of fluoroquinolones involves inhibition of bacterial DNA synthesis, resulting in rapid bacterial cell death. And this happens by inhibition of two different enzymes. So they can inhibit DNA gyrase, often in gram-negative bacteria. They can also inhibit topoisomerase 4, often in gram-positive bacteria, which results in DNA synthesis interruption. Fluoroquinolones are available as PO and IV for the most part, which can be used for UTIs. Now, there are other formulations, for example, eardrops, eye drops that are not covered in this topic. Fosfomycin is only available as oral in the United States currently, and an IV formulation is under development. And the way it works is that it inhibits MUR-A, which essentially inhibits initial step in bacterial cell wall synthesis. Nitrofurantoin is also only available as an oral option, and there are three proposed mechanisms of actions for it, which include inhibition of ribosomal translation, bacterial DNA damage, or interference with the Krebs cycle, or citric acid cycle. Finally, we have the combination of trimethoprim, sulfamethoxazole, which together are available as both oral and IV, which are used commonly for the treatment of UTIs. And the way they work is that sulfonamides inhibit the formation of dihydrofolic acid, and trimethoprim prevents the next step, which would be the synthesis of tetrahydrofolic acid, which in turn inhibits DNA synthesis. Now, let's take a look at some beta-lactams. So, pivmecillinam, which is an aminopenicillin, and other aminopenicillins include amoxicillin and ampicillin. But unlike those two agents, pivmecillinam is an excellent agent for use in urinary tract infections. Although its bioavailability, similar to other oral beta-lactam, is low, about 25 to 35%, it does achieve high concentrations in the kidneys. Now, this is a prodrug, so the active drug, which is mesillinam, it is primarily excreted in the urine, so 80% of it goes unchanged in the urine. And just like any beta-lactam, they act by cell wall synthesis. They bind to penicillin-binding proteins, and it is bactericidal. Now, some other beta-lactams that are commonly used in UTIs is first-generation cephalosporin cefazolin, which is only available as IV. Which has activity against E. coli, but it depends on local susceptibility rates. So E. coli may or may not be resistant to cefazolin. Ceftriaxone, which is a third generation cephalosporin and is also available as IV, has much more stable activity against E. coli. So in general, if we don't know susceptibility results, ceftriaxone has more reliable activity against E. coli. And for more severe UTIs, typically aminoglycosides are also available as an option. So gentamicin is one of them, and in general, aminoglycosides inhibit protein synthesis by binding to the 38 subunits of the ribosome. But there are more severe toxicities with aminoglycosides, including nephrotoxicity as well as ototoxicity. Let's take a look at the adverse effects of these antibiotics. Trimethoprim can lead to anemia, leukopenia, thrombocytopenia, hyperkalemia, and hyponatremia. And hyperkalemia is something that occurs in clinical practice often and is something to monitor with patients. Trimethoprim can also inhibit the secretion of serum creatinine in the kidneys, which means that artificially serum creatinine will be increased, but doesn't necessarily mean nephrotoxicity. Sulfamethoxazole, however, can cause nephrotoxicity. So because these two come together, so together this combination is considered nephrotoxic. And sulfamethoxazole, which is a sulfa drug, that component can cause rash, photosensitivity. It can also cause GI upset like nausea, vomiting, diarrhea, as well as hepatitis, anemia, thrombocytopenia. And it is recommended that the patients actually take this combination with at least 8 fluid ounces of water in order to avoid formation of crystals in the kidneys, in order to avoid or at least reduce the risk of nephrotoxicity. It is also advised for the patients to use sunscreen and avoid tanning beds because of the photosensitivity. Nitrofurantoin can also cause GI disturbances as well as CNS effects, such as headache and drowsiness. It can also lead to allergic reactions that often present as leukopenia, granulocytopenia, eosinophilia, and hemolytic anemia. And hemolytic anemia is often present in people with glucose 6-phosphate dehydrogenase deficiency. It can also cause peripheral neuropathy, interstitial pneumonitis, and it can also make the urine color change to brownish color. And with chronic use, it can also cause pulmonary fibrosis. Lastly, it can cause hyperkalemia. It is recommended that nitrofurantoin be taken with food to improve absorption and avoid concurrent magnesium products, which can reduce the absorption. Fosfomycin is currently available as oral, and it comes in packets that include powder, and the patients need to mix it with 3 to 4 fluid ounces of cool water, so it should not be done in hot water. And it can cause diarrhea, nausea, headache, vaginitis, as well as dizziness, abdominal pain, as well as rash. Now, a lot of bad things happen with fluoroquinolones in general. So let's focus on ciprofloxacin. So with ciprofloxacin, like many antibiotics, GI disturbances can occur. So nausea, vomiting, diarrhea, abdominal pain. But with fluoroquinolones, you can also have CNS effects like headache, dizziness, hallucination, delirium, and in some cases, seizures have happened, including in patients who had underlying neurological disorders, and also like patients who were taking NSAIDs. So NSAIDs can increase the risk of having seizures with fluoroquinolones. There's also been reports of peripheral neuropathy that may be irreversible, as well as arthralgia and joint pain, tendon rupture or tendinitis, and these basically occur mostly in elderly patients over the age of 60. They are at high risk. Fluoroquinolones can also lead to QTc prolongation. Now, ciprofloxacin has the lowest risk compared to other fluoroquinolones, but the risk still exists. It can also cause rash and photosensitivity. It is recommended that patients avoid taking any dairy products. So anything that includes a cation such as calcium should be avoided. So they should be separated by at least 2 hours. And just as in any product that causes photosensitivity, patients should use sunscreen and avoid tanning beds and avoid excessive exposure to sunlight. Let's take a look at different formulations of nitrofurantoin. So when first it came to the market in 1952, it was in macrocrystalline form, which, it had improved absorption, but it also came with a lot of adverse effects, specifically GI adverse effects that made it difficult to tolerate for patients. Later, by 1967, the macrocrystalline formulation was developed that improved GI adverse effects so people could tolerate it. Unfortunately, it came at the cost of absorption. So because it was not absorbed, this had to be taken 4 times a day. And this still is available on the market as macrodantin. And later, a mixture of macrocrystalline and macrocrystalline formulation was developed. So about 25 milligram macrocrystalline plus 75 milligram of macrocrystalline. So this was a little compromise. So improved absorption with a little GI adverse effect. So Macrobit, which is the preferred nitrofurantoin formulation, is available on the market, and this is 100 milligram given 2 times a day BID, and that's in the name Macrobit BID. Now, it is contraindicated in the package insert in patients with creatinine clearance less than 60. However, clinically, we do use it as long as creatinine clearance is over 30, and you can see Beer's criteria to support this recommendation. Now, here's how the spectrum of coverage of nitrofurantoin compares to some of the other oral agents. So nitrofurantoin is active against MSSA. It may or may not be active against MRSA, so it has to be tested. It is good against VRE and excellent activity against E. coli, so the resistance pretty rare. However, if it is an ESBL producing E. coli, it is likely to be resistant to nitrofurantoin as well. Whereas fosfomycin and pivmesolinam are stable, where pivmesolinam is a beta-lactam, so it's stable against ESBL, and ESBL producing E. coli typically happen to be susceptible to fosfomycin as well. So fosfomycin and pivmesolinam good options for ESBL. ESBL producing also tend to be resistant to trimsulfa as well. Now, pivmesolinam is very targeted at E. coli, Klebsiella, and some of the Enterobacterialis. And you can see that it hardly has activity against some other organisms, specifically gram-positive. However, because we get very high concentration of pivmesolinam in the urine specifically, it does happen to kill some of these gram-positives like Enterococcus, but in general, it's considered at least in vitro to be resistant. These organisms are resistant to pivmesolinam.
Because there are different formulations of nitrofurantoin, and if you're working with the generic, it just says nitrofurantoin on it. So it's important to be able, as pharmacists, to distinguish between the 2 formulations. So as you can see, choice A, it actually tells you that this is monohydrate macrocrystals combination, whereas the second is just macrocrystals. So this question is which is the generic for Macrobit. The correct answer would be A. It also tells you here, so A is Macrobit. It says that it's dosed twice a day, take it with food. Whereas the second option, it tells you, let's see, QID, so 4 times a day with food. So that's how you know choice A is Macrobit. So as pharmacists, you should be aware of, if the doctor wrote for Macrobit, don't dispense the second option, especially if the instruction says take 1 pill twice a day. You do not want to give them this because it's not going to be absorbed as much, and you're going
Now, gepotidacin or blue gepa is a new class of antibiotic that is approved for treatment of cystitis. It is a triazoacinaphthalene bacterial type 2 topoisomerase inhibitor, so it works similar to fluoroquinolones, but you will see that it actually has a different site of binding than fluoroquinolones. So the idea behind this drug is that if we have organisms resistant to fluoroquinolones, they could potentially be still susceptible to gepotidacin. So it's designed for those organisms resistant to fluoroquinolones, as the rate of resistance to fluoroquinolones is increasing over time. It is a bactericidal agent with a PK/PD target of AUC to MIC, and the most common observed adverse effects include GI adverse effects such as diarrhea, nausea, abdominal pain, flatulence, vomiting, as well as headache, dizziness, and QTc prolongation. The spectrum of activity of this drug essentially is gram-positive, such as MSSA, MRSA, beta-hemolytic strep, and E. faecalis. It most likely doesn't have activity against E. faecium, which tends to be VRE species. It has good activities against most gram-negatives, including Enterobacterialis. However, it does not have activity against Pseudomonas. It is also active against anaerobes such as Bacteroides, as well as atypical agent.
Have failure, treatment failure.
Now let's take a look at sulfonamide allergy, which is often referred to as sulfa allergy. Now about 3 to 8% of patients report experience with sulfonamide allergies, and in general all sulfonamides, which can be divided in sulfonamide antibiotics and sulfonamide non-antibiotic agents, they basically all contain a sulfa moiety. And then sulfonamide antibiotics also contain additional substitutions at N1 and N4 positions. And the evidence currently suggests that these substitutions at N1 and N4 are the primary determinants of drug allergy instead of the common sulfonamide moiety. So based on the evidence that's available currently, there is a very low risk of cross-allergenicity between sulfonamide antibiotics and non-antibiotic agents. So when you hear a patient have a sulfa allergy, you should determine if it was due to a antibiotics sulfonamide or a non-antibiotic sulfonamide. And in general, sulfonamide non-antibiotic agents include loop diuretics like furosemide, thiazide diuretics, so hydrochlorothiazide, for example, sulfonylureas, triptans that are used for migraine, acetazolamide, celecoxib, which is a COX-2 inhibitor, as well as some protease inhibitors for HIV, such as darunavir. And sulfonamide antibiotics, for the most part, include sulfamethoxazole, which we use for UTIs in combination with trimethoprim, but there's also sulfadiazine as well as sulfasalazine. So rechallenge and desensitization strategies may be appropriate for patients with sulfonamide allergy with delayed maculopapular eruptions, but alternative treatment options are more appropriate for patients with severe infections. We described the pharmacokinetic and pharmacodynamic properties of antibiotics used for UTIs. Now let's distinguish UTI presentations by symptoms and urinalysis findings and classify each case as uncomplicated or complicated. Let's take a look at some key definitions. When you get a urine sample from a patient, for most individuals there will be no bacteria in the urine. The urine is supposed to be sterile, especially in men, and we call this sterile urine. Now, if you find bacteria in the urine sample, this could be due to contamination of the sample. This could be from the skin of the patient or from the environment. Once you rule out contamination, if there are bacteria in the urine, we call this bacteriuria. This means the presence of bacteria in the urine. If a patient with bacteriuria has no symptoms, we call this asymptomatic bacteriuria. This is not a urinary infection and does not need to be treated in most patients. If the patient does have symptoms, however, we call this symptomatic bacteriuria, or more commonly known as urinary tract infections. What exactly are these symptoms? The four most common symptoms are frequency, so the patient has to urinate small amounts frequently, and it will be painful, which we call dysuria. There will also be urgency, or the urge to void immediately, and there can also be hematuria, or the presence of blood in the urine. As I mentioned earlier, there are different types of UTIs. The most common one is cystitis, or the infection of the bladder. There is also pyelonephritis, which is not as common but is very important. Symptoms that are more specific to pyelonephritis include fever, which is not always present, but if it is suggestive of pyelonephritis. There will also be CVA tenderness or flank pain. CVA tenderness is detected during physical exam, typically by a physician as they tap on the back of the kidneys with their fingers. UTIs can also be considered uncomplicated or complicated. For example, there's uncomplicated cystitis or there is complicated cystitis. Let's take a closer look. Now, in 2025, IDSA released new guidelines for management and treatment of complicated urinary tract infections, where they defined complicated and uncomplicated UTI. So here on the left hand side, you can see the old classifications for your reference. But importantly, here's the new definitions of uncomplicated UTI, which is essentially infection confined to the bladder. So essentially cystitis in afebrile women or men. So gender doesn't really matter. But you know, as long as there is no fever, the cystitis is considered uncomplicated. Whereas pyelonephritis is just considered complicated, period. Whereas any infection beyond the bladder, so even if the patient has bacteremia as a result of UTI, that means it has advanced beyond the bladder, so it will be complicated. If patients have catheter associated UTI, or in men specifically if there is a suspicion of prostatitis, these are the definitions of complicated UTI.
Now here's some definitions of different types of collection techniques for the urine specimen, and this slide is just for your information. So voided urine or random specimen. This is basically the most commonly used method by most labs. So this is basically where a cup is given to the patient and they basically urinate in it. So it's very important for the patient to not contaminate the sample. So it's important for them to not touch it. And, as you can see, as you can imagine, it would be possible, as the urine is coming out, it could basically pick up bacteria from the skin. So it's possible that it could be contaminated, but this is easy and most commonly used. Another method is midstream clean catch urine, so most commonly referred to as clean catch. The reason this is preferred, but it's not as easy, is because this is less likely to be contaminated. So basically the patients are actually required to cleanse the area first, and then they're going to void the first portion of the urine into the toilet, and then the remaining urine into the cup. That way, hopefully, the urine is less likely to pick up bacteria from the skin as the urine comes out. The next method is catheterized urine. So this is basically done in patients who have a Foley catheter in place. So this is common in the hospital, especially a lot of the patients in the hospital already have a Foley catheter in place for various reasons. So if so, you can easily collect the urine and avoid any contamination. And there's also suprapubic aspirate. This is basically a needle is used to go directly into the bladder and pull urine out. So it's not as commonly used, but occasionally if there's obstruction and the patient is unable to actually urinate, and there's but the kidneys work and the urine is being produced, we can actually go directly into the bladder and draw the urine out. I know sometimes this is done just to get rid of the urine. And sometimes it's also done to get the sample to send to the microbiology lab. So here's what happens in the micro lab. So urinalysis is the easiest thing you can do, is the cheapest thing we can do, and it's the most commonly done thing in the hospital. So once you get your urine sample, and it comes to the micro lab, the first thing they do, they have these strips for urinalysis. So they have these strips are they have different sections on it, and what they do is that it's basically a dipstick. So they just dip it into the urine, and as the color of different sections change, they basically interpret it based on the color. So this is immediate. So as they dip it into the urine, the colors change and they can see it. So you get the results the same day that the urine sample is sent to the micro lab. And you don't need to memorize this or anything. It's just for your information. But basically, there are, based on the color, they will tell you, the results of the UA or urinalysis. So I'll give you one example. So for example, one thing that they look for is the presence of nitrite. So there's a section on the strip for nitrite. So basically they just see how the color changed, and they will tell you if it's negative or kind of positive, and then definitely positive. And you can do this for other things. For example, if they wanted to see if there's glucose present, if it's yellow for this particular test, they would say it's normal, and so on. So here's what you really need to know. So once the results of the urinalysis is reported, you need to be able to interpret it. So a normal urine, it's supposed to be clear and yellow. So if you find it to be cloudy, it can be due to different reasons. Either there's an infection, or especially in patients who have kidney disease, because there's damage to the kidney and things that are not supposed to be there find their ways into the urine, such as protein or any other chemical from the body, it will make it look cloudy. So cloudy doesn't necessarily mean infection, but it could. Another thing that's important to look at is the presence of nitrite and leukocyte esterase. So if nitrite is not supposed to be there in the urine, so if you do find nitrite in the urine, it could suggest the presence of bacteria. Now, if the nitrite is not there, doesn't necessarily mean that there is no infection, and I'll explain that more on the next slide. If you find leukocyte esterase, that means there white blood cells are present, because these esterases are released from the actual white blood cell from the body. So if you do find the leukocyte esterase, that just means that there are white blood cells present, and we call this pyuria. So pyuria means the presence of pus in the urine, or more specifically, the presence of white blood cells or leukocytes in the urine. And you can actually measure how much white blood cell is in the urine. So the exact definition of pyuria would be if you have white blood cell of more than 10, then we call this pyuria. Of course, you can also see if there are bacteria in the urine. So the presence of bacteria, we call this bacteriuria. However, note that in a urinalysis, if you do find bacteria, this could be due to contamination. So this may not necessarily be bacteriuria, it could be just contamination. And the way that we check for contamination is that we look at epithelial cells. So epithelial cells are from the skin, so you shouldn't have it in the urine. So if you do find significant amount of epithelial cells in the urine, that means they're coming from the skin, which means that your sample is contaminated. So if you do find bacteria and epithelial cells significantly, you have two options. Either you really have bacteriuria in the patient and also it got contaminated, or the patient doesn't really have bacteriuria, but it got contaminated. And the only way to distinguish that is by actually doing a urine culture and see if we can grow actual bacteria. But epithelial cell is what you look for to see if the sample is contaminated. And then if you have casts, there are different types of casts that are used to assess kidney function. If the patient has pyelonephritis can also cause some damage to the kidney, which kind of explains why you will see casts. So if you do find casts in the UA, doesn't necessarily mean pyelonephritis. It could mean either the patient has AKI or CKD, or it could be pyelonephritis. So these are things that are used in combination when you do patient assessment. So for example, if the patient normally has if the patient doesn't have a history of kidney disease, but suddenly comes to the hospital with fever and flank pain, and you see casts on the UA, that could suggest that the patient could possibly have pyelonephritis, and the physician will do further imaging to confirm the diagnosis. Let's see what else I didn't talk about. Oh, the pH. Some organisms such as Proteus mirabilis are capable of splitting urea, which will increase pH. So occasionally you will see that the pH will be higher than the normal range. And that kind of helps you suspect Proteus mirabilis, so when you choose antimicrobial agents. Okay, so bacteriuria, I talked about sterile pyuria. Sometimes you will not have bacteria in the urine, but you will see white blood cell increase. That's what they refer to as sterile pyuria. So pyuria, that means pus is present, white blood cell. So there's some sort of infection going on, but it's sterile because you didn't see any bacteria. So this can be due to different reasons, but one would be, for example, if a patient has a viral infection, you will still get a white blood cell response, but there will be no bacteria. So that's just important to know, because if you get sterile pyuria, sure, the patient has some sort of infection, but you don't need antibiotics to treat it because you didn't see bacteria. And of course, you would like the urine to be, you would like to see sterile urine in most patients, and it's important to rule out contamination. So here's the nitrate cycle. So basically, nitrates are important. As you eat food, nitrate will be part of the food that comes into the body, and of course, the bacteria that are part of the flora will use nitrate, as food. And this cycle continues. However, by the time it makes it back to the urine, you will still have nitrate. So nitrate goes back and forth by bacteria. Bacteria will convert nitrate to nitrite, but the end product that goes actually to the kidneys is nitrate itself. So nitrate comes from the food and also is excreted to the urine. So by the time it goes to the urine, you should only see nitrate. And what we check on urinalysis is nitrite. So because you are only supposed to have nitrate in the urine and not nitrite, and you're not really supposed to have bacteria in the urine, if you do find nitrite in the urine, that could suggest that there are nitrate reducing bacteria in the urine that are converting the nitrate, which is supposed to be there, into nitrite. So that's why we check for nitrite. If we detect it, you suspect that there are bacteria converting the nitrate in the urine to nitrite. And there are nitrate reducing bacteria such as Enterobacteriaceae. So most common member of Enterobacteriaceae family is E. coli, and also Pseudomonas. So that's what we suspect. Now, the reason I mentioned earlier that if you do not find nitrite in the urine doesn't necessarily mean that there are no bacteria is because if you have too much of these bacteria, once they run out of nitrates, then they start to use nitrite as food and convert it to ammonia. So if you have too much bacteria, then nitrite, they will use all of the nitrite. So when you do your test, then nitrite shows up negative. So that's why if it's positive, it suggests there are bacteria. But if it's negative, doesn't necessarily mean that there are no bacteria. Of course, if you don't have bacteria, nitrite would be negative. But if you have too much of nitrate-reducing bacteria, you will also not see nitrite. To make it more complicated, there are also non-nitrate-reducing bacteria. So if you have any of these in the urine, they're not going to touch the nitrate, so your nitrite will be negative again. So it's not a perfect test. If nitrite is positive, it suggests that there are bacteria, but if it's negative, you need to keep looking.
We described the PK/PD properties of antibiotics used for UTIs, distinguished UTI presentations by symptoms and urinalysis findings, and classified each case as uncomplicated or complicated. Now let's ensure urine cultures are taken in patients with pyelonephritis or recurrent cystitis. It's helpful to think of severity of urinary tract infections. On the one end of the spectrum, we have cystitis, which is less severe, and then more severe than cystitis, we have pyelonephritis, and when that leads to bacteremia, of course, that would be more severe, and then if that leads to sepsis, occasionally referred to as urosepsis, that would be the most severe, putting patients at risk of mortality. Cystitis is a benign infection. It may actually resolve or it may progress to pyelonephritis if untreated. Pyelonephritis is considered a severe infection. It can progress to bacteremia, so therefore we need urine and sometimes blood cultures. So if we anticipate bacteremia, we may need to get blood cultures to assess that in the patients. Sepsis caused by UTIs is a very severe infection, and we need urine culture and blood cultures to assess patients appropriately. And often patients are admitted to the hospital because this is considered an emergency. And in fact, because of the high risk of mortality, it is important for patients to go to the emergency department. Whereas cystitis is very benign and it can be treated outpatients. There is no need for IV antibiotics. And I'm talking about an initial cystitis as opposed to recurrent cystitis where there is no need for cultures, and it can be treated in the primary care physician's office. And then pyelonephritis is in between, so patients don't necessarily need to go to an emergency department, which is often costly, and there is a high, usually long wait list. So patients can go to an urgent care clinic in order to receive IV antibiotics and receive a urine culture and essentially start their treatment there. So who exactly should get urine cultures? For pyelonephritis, because it is a severe infection and cultures are needed to ensure appropriate therapy. So everybody with pyelonephritis needs urine cultures. And then recurrent cystitis is likely to be due to resistant E. coli or other resistant organisms. So cultures are needed to ensure appropriate therapy is selected in patients with recurrent cystitis. And complicated UTI, which includes pyelonephritis and other infections that go beyond the bladder, is more likely to be due to resistant pathogens, and cultures are needed to ensure appropriate therapy is selected. We described the PK/PD properties of antibiotics used for UTIs and distinguished UTI presentations by symptoms and urinalysis findings, and ensured urine cultures are taken in patients with pyelonephritis or recurrent cystitis. Now let's list the top 4 common uropathogens that cause UTIs.
So here on the left, I have uncomplicated UTI, which is the focus of this topic. And this could be cystitis or pyelonephritis. But as you can see, the number one organism that causes these uncomplicated UTIs is E. coli. So E. coli is the number one organism. You should always cover for E. coli. So whatever agent you choose, you need to make sure that it has a good coverage for E. coli. And then outside of that, you have Klebsiella pneumoniae causing a lot of these infections, and also Staphylococcus saprophyticus, as well as Enterococcus. So these are your top 4 organisms that commonly cause urinary tract infections. Now, note that like other organisms can cause UTIs, but they're not as common. So Pseudomonas, for example, Pseudomonas aeruginosa, there's about like 1% case. So you don't need agents that cover Pseudomonas for every patient. Occasionally, by occasion I mean like there's like 1% chance that they may need it, and by then we will have cultures and basically if that 1% shows up is when your antibiotic is not working, and then we get cultures and then you find Pseudomonas. But you do not want to cover for Pseudomonas for every patient with UTI. You want to target the top 4. And of course, when it comes to complicated UTI, you start to, still E. coli is your number one organism, along with Klebsiella and Enterococcus. However, note that in complicated UTI, you do start to see more of Candida species causing UTI due to Candida, or Candiduria as we call it. Now, I know, so in complicated UTI, they are more likely to be due to resistant organism. So, for example, look at Pseudomonas. So, Pseudomonas are more likely to cause complicated UTI, but still is around 2%. So, it's still something that you do not want to cover empirically for everyone. So, you do not need to cover for Pseudomonas for patients with complicated UTI. If you happen to find it on the urine culture, that's when we cover, we use an agent to treat it. Otherwise, empirically, we target the majority. So you need to target the top 4, and in this case, also Candida when we talk about complicated UTI. But I want you guys to focus on uncomplicated UTI. So just know these top 4 agents cause uncomplicated UTI.
We describe the PK/PD properties of antibiotics used for UTIs and distinguish UTI presentations by symptoms and urinalysis findings and classified each case as uncomplicated or complicated. We then ensured urine cultures are taken in patients with pyelonephritis or recurrent cystitis, and we listed the top 4 common uropathogens that cause UTIs. Now, given a patient case, let's recommend effective drug therapy for treatment of cystitis or pyelonephritis. Now, for treatment of uncomplicated cystitis, we will use the 2010 IDSA guidelines for treatment of cystitis and pyelonephritis in women. Those guidelines also covered pyelonephritis, but we will ignore recommendations for pyelonephritis because the new 2025 IDSA guideline for complicated UTIs covers pyelonephritis. So for cystitis specifically, fluoroquinolones should not be used as first-line agents for empiric treatment of cystitis because of their high propensity for collateral damage, meaning ecologic adverse effects, and the benign nature of cystitis. Oral beta-lactams also have lower efficacy in general and should not be used as first-line agents. And in fact, the guidelines specifically say avoid amoxicillin and ampicillin due to poor efficacy. The IDSA guidelines recommend trimsulfa or trimethoprim sulfamethoxazole as a first-line option, but should be avoided for empiric treatment of cystitis because local E. coli resistance rate is more than 20% across the United States. In fact, a study that was published in 2016 and looked at the prevalence of resistance up to the year 2012, you can see that for nitrofurantoin, and we're looking at different age groups. So for age 18 to 64 and then age 65 and higher, you can see that the resistance rate was pretty much under 5% for nitrofurantoin, and this is resistant to of E. coli specifically to these antibiotics. For trimsulfa, you can see that in the year 2012, the resistance rate has been more than 20%, has increased to more than 20% for all age groups. For ciprofloxacin, the rate of resistance has also gone up, especially for elderly. You can see that for age 65 and higher, the rate is over 20%. Which means that we have 3 oral agents available as first line for treatment of uncomplicated cystitis in women. And this is in the guidelines are focused on women because cystitis is rare in men. So, and in fact, clinical trials of cystitis have mostly been done in women. So these recommendations are for women. Now, if you encounter a patient who is a man, you can still apply the same recommendations, but keep in mind that most of cases of uncomplicated cystitis will occur in women. So the first drug is nitrofurantoin, specifically the macrobid formulation is recommended for 5 days, and you can see that the most adverse effects of nitrofurantoin is GI disturbances, so nausea, vomiting, also headache, and although some adverse effects such as pulmonary fibrosis are listed here, they are uncommon when you use only 5 days. When you really use this drug in long term, for example, for suppression or prevention of UTI, for example, after 1 to 6 months of therapy, when you get to see some of these rare adverse effects. One thing to note about nitrofurantoin, because it's commonly used, is that in the package insert, it's listed that its use in creatinine clearance less than 60 is contraindicated. However, in real world, we do use them even in patients with creatinine clearance of 30 to 60. In fact, you can use Beer's criteria guidelines for geriatric population. In that guideline, they actually do recommend it to be used between creatinine clearance of 30 to 60, even though the package insert says it's contraindicated. Next, we have fosfomycin, which is a single dose, so it's a 3 gram. This comes in a little pouch, so it's in powder form that patients have to mix in water, and you just take it once. Common adverse effects, again, GI adverse effects as well as headache. And the last one, which is pivmecillinam, is a very old drug but became available in the US only in the last couple of years. And this is for 3 days. And similar to other beta-lactams, this is likely to cause GI disturbances. And one thing to note about pivmecillinam is that the dosing that's recommended in the guidelines is different than what's in the package insert. So the package insert recommends 3 times a day dosing for 3 to 7 days, whereas the guideline has the twice daily dosing, which makes it easier for adherence. Also with nitrofurantoin, keep in mind that it's dosed 2 times a day for 5 days. So, when it comes to adherence, perhaps fosfomycin is more friendly, but probably the most effective among the 3 would be nitrofurantoin. So most commonly, nitrofurantoin is used for treatment of uncomplicated cystitis. Now let's switch gears and take a look at the new guidelines for complicated UTI, which essentially includes pyelonephritis and anything that goes beyond the bladder. Now, with this guideline, because it becomes more serious, they do ask that you assess the severity of infection and identify patients who happen to have sepsis or septic shock. And as a reminder, we have discussed this before, so we are using sepsis definition from 2016, so sepsis 3, which is essentially the presence or suspicion of an infection plus at least a 2-point increase on the SOFA score from baseline. And the definition of septic shock is essentially patients with sepsis who require vasopressors because their low hypoperfusion is unresponsive to adequate fluid resuscitation, and they need to have a serum lactate of more than 2 millimoles per liter. Now let's take a look at the preferred and alternative available agents for patients with sepsis. So essentially, 3rd generation and 4th generation cephalosporins, piperacillin, tazobactam, fluoroquinolones, and carbapenems are preferred agents. And on the next slide, we will talk about what to consider when you choose one of these first line agents. In other words, we're not going to randomly pick something from this list. We're going to use patient specific factors and other things that we will discuss shortly. Now, alternatively, the patient can be on aminoglycosides, and aminoglycosides are very nephrotoxic, so that's why they're not preferred. And then we have the big guns. So we have novel beta-lactamase inhibitors that are reserved for very resistant organisms, so organisms that are resistant to carbapenems and some of these other preferred agents. The same is true for cefiderocol. So cefiderocol is reserved for very resistant organisms. Now, if the patient does not have sepsis, you have the choice of IV route or PO route, because for sepsis, all of these agents, they are only available as IV, so you don't even need to, with the exception of fluoroquinolones that are available in as a oral, pretty much you want to do IV antibiotics. So even 3rd generation cephalosporin, some of them are available as PO, but you pretty much want to start as IV because of the severity of disease. And that's because patients may not be able to tolerate oral. So they may be nauseated, they may be vomiting, or they might have GI issues that prevents absorption of oral medications, as well as, because we have to wait for the absorption, that can actually delay the presence of antibiotics at the site of infection. So that's all reason to use IV antibiotics in the presence of sepsis or septic shock. But in the absence of sepsis, because the risk of mortality is extremely low, you have the option of IV or PO, and you have to use your clinical judgment, again, to see if someone can tolerate PO or should they receive IV initially. So we are talking about empiric treatment initially before we have the results of urine cultures. So essentially, because there is no sepsis, what you will not see listed as preferred is carbapenems. So should not be using carbapenems. So carbapenems will be alternative. So you should reserve it for patients that are at risk of resistant to some of the first line agents, which are third and fourth generation cephalosporins, peptazo, and fluoroquinolones. And then for patients that we can use PO, options include oral fluoroquinolones and of course oral trimsulfa. And then alternatively, we have oral beta-lactams such as amoxicillin clavulanate and select oral cephalosporins that we will discuss shortly on which agents specifically. One thing to keep in mind is that you should use clinical judgment to decide whether the patient is likely to have non-enterobacterialis organisms. For example, if a UTI is caused by Enterococcus or Pseudomonas or even MRSA, or a highly resistant urinary pathogen based on prior culture and antibiotic exposure. And that's when you would lead people to use some of the alternative agents and also to choose carefully from preferred agents. Now, Staphylococcus aureus is not a common cause of UTI. Occasionally, for example, someone who has a suprapubic catheter, so that's essentially a catheter that goes from the outside through the skin into the bladder to help someone avoid their urine. And that essentially opens the door for skin organisms to get into the bladder. So that's the one of the examples of where you would potentially have MRSA making its way into the urine and cause an MRSA urinary tract infection. So it's rare, but it's possible. The other is that if someone already has MRSA bacteremia as a result of another source, and then because blood goes to the urine, MRSA can actually make its way through the descending path and cause urinary tract infection. So those are two potential possibilities for MRSA. So again, use your judgment to see if pretty much these agents do not, most of these agents do not have MRSA activity. So if you encounter such a situation, you should make sure that you have MRSA activity on board, which again is extremely rare. Now let's take a look at some factors to consider when choosing from those lists. So patient-specific risk factors for resistant neuropathogen. So essentially, the guidelines recommend to avoid antibiotics to which the patient has had a resistant pathogen isolated from the urine in the past 12 months. So if somebody just had a pyelonephritis and you find a urine culture from 6 months ago and you see that it was E. coli resistant to fluoroquinolone, then you should suspect fluoroquinolone resistant. Or if you saw third generation cephalosporin resistant, you should suspect third generation cephalosporin. The same with trimsulfa. Now there's only these three are listed because these are the three that have been studied, but you can anticipate the same principle could apply to other agents. For example, let's say if somebody had E. coli resistant to cefepime, which is a fourth gen from 6 months ago, you should probably anticipate cefepime resistance. Now, that doesn't mean that there is 100% that you will see the same resistance. This is just telling you that there is a very high likelihood to see that resistance. So when you're guessing empirically, you should keep this in mind. Of course, when the urine culture results come back, you should tailor the treatment based on the results of that. The next thing to consider is avoid fluoroquinolones if the patient has been exposed to fluoroquinolones in the past 12 months. In other words, if 6 months ago the patient took fluoroquinolone for whatever reason, so let's say for another infection, not even a UTI, you should anticipate that there could potentially be resistant to fluoroquinolones just because there is a high propensity for gram-negative organisms to develop resistance to fluoroquinolones once they see fluoroquinolones. Now, other patient-specific considerations include risk of allergic reaction. So you can, essentially eliminate options from the preferred list. If the patient has allergy to one of the agents, or if you find other contraindications, or if you potentially find drug-drug interactions. So that should be something to keep in mind. And lastly, when it comes to sepsis specifically, because empirically we are guessing, which agents would most likely cover the causative pathogen, the guidelines recommend to use antibiograms to help you. If the antibiogram is local, it is recent, so in the last year, and relevant. For example, if you have a antibiogram specifically based on urinary isolates, then you can use that. Now, they make no recommendation for or against using antibiograms outside of sepsis because there is not much evidence to show that whether it makes a difference if you use an antibiogram. But again, if you have it available, by all means, you can use it. For sepsis is when they say that it will likely make an improvement of outcomes. And with sepsis, you want to choose something that has at least 80% susceptibility for the pathogen that you're anticipating. So most likely we're looking at E. coli, but if for some reason you were anticipating Pseudomonas, then you should be looking at susceptibility of Pseudomonas to the agent that you're choosing. And for septic shock, they're saying the threshold should be 90%. So because people are much more likely to die if we get it wrong, you want to choose agents that have at least 90% susceptibility on the antibiogram. For patients who were initially on parenteral antibiotics, these are the criteria for transitioning from IV to PO. So it's always best to transition to PO because oral antibiotics are less likely to have complications, and also gets patients ready for potential discharge from the hospital if the patients are in the hospital. So first thing is we have to make sure that the patient is clinically improving. It's difficult if the patient is not improving, it's difficult to make an argument for switching from IV to PO. And the patient should be able to take oral medications. In other words, there should be no malabsorption, no short bowel syndrome, no ileus, which is an obstruction, no severe diarrhea, no motility disorders, no vomiting, no delayed gastric emptying, or no reduced gut perfusion due to shock. These will essentially reduce the efficacy of oral antibiotics. The third thing to consider is an effective oral option should be available. So if you have ruled out the other all the options on the list, then you're out of luck. So what they mean by effective is that based on the urine culture, you have to make sure that the agents are active against the causative pathogen, and to make sure that they achieve therapeutic levels in the urine and relevant tissues. And by relevant tissue, for example, if someone has pyelonephritis, you have to make sure there is sufficient concentration of the drug, not just in the urine, but also in the parenchymal tissue in the kidneys. Or if someone has bacteremia, you have to make sure there is sufficient levels of the drug in the blood. Fourth thing to consider is, if applicable, source control should be achieved. And most commonly in urinary tract infections, if the patient has urinary obstruction, that's what needs to be controlled. So the relief of urinary obstruction. And lastly, there are no patient-level psychological or economic factors that would favor the IV route. In other words, if you're sending someone home on a prescription of oral antibiotics, but they don't have access to getting that prescription filled, then that's a reason to keep them on IV in the hospital and finish the course before sending them home. Now, here are considerations when choosing oral agents for treatment of complicated UTIs. So in general, avoid ampicillin, cefadroxil, cefaclor, cefdinir due to poor bioavailability. And this table just showcasing what percentage of these oral agents are absorbed, and then of what's absorbed, how much of it actually goes to the urine. And some typical doses, which you don't need to memorize, but what you need to understand is that so you obviously avoid the ones that are listed in red here because of poor bioavailability. But should you need an oral agent, the high bioavailability agents include fluoroquinolones, so ciprofloxacin and levofloxacin have excellent bioavailability, as well as trimsulfa. And then beta-lactams in general considered to have poor bioavailability. A couple of exceptions are cephalexin, which has a great 90% absorption, as well as amoxicillin clavulanate, which has high oral absorption. So should you need an oral beta-lactam, it's recommended to use either amoxicillin clavulanate or cephalexin, and when you do use them, use pretty much higher doses than typically used or listed in common drug information resources, just to make sure that you improve the efficacy for this indication. So we looked at symptoms of cystitis and pyelonephritis. We analyzed the results of urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis. We also recommended effective drug therapy for treatment of cystitis and pyelonephritis. Now, the next learning objective is change empiric therapy to pathogen-directed therapy based on urine cultures and susceptibility results. The concept of collateral damage refers to unintended ecological adverse effects of antibiotic therapies, and this includes selection of drug-resistant organisms as well as unwanted development of colonization or even infection with multi-drug resistant organisms. Here's how selective pressure works. The normal flora includes a diverse population of bacteria, and this diversity is beneficial for health, because these organisms can actually compete with pathogenic bacteria for growth. So they actually prohibit the growth of pathogens. Although these bacteria are beneficial for health, some of them could actually include genes for resistance. So imagine these two strains of bacteria that are pink, they actually include genes for resistance. Although they are resistant to antibiotics, they are not really causing any infection or any problems in the host. Now imagine that you start using antibiotics for an infection. While the antibiotic is important for killing the infection, the antibiotic can also kill all these beneficial flora. And when it happens, all the flora that are susceptible to the antibiotic will die, except those beneficial bacteria that were resistant. And because those resistant bacteria, although they are not causing any problem, because they stay around, they actually become the dominant species as part of the flora. And now, the majority of the flora include genes for resistance. And then when the day comes when an actual pathogen invades the host and causes infection, these flora can actually transfer those resistant genes to the pathogenic bacteria from plasmids and cause infections that are resistant to antibiotic. And this is referred to as selective pressure, where the resistant organism becomes the dominant species. This selective pressure is greatest with broadest antibiotics, and the risk is lowest with narrowest antibiotics. So therefore, it is important to keep that in mind, and when we select antimicrobial agents for our patients, to choose the narrowest possible option. This pyramid is designed to help you understand broad versus narrow spectrum of activity. It is important to know that there is no such thing as a tiering system when it comes to broad versus narrow spectrum of activity. I have created this pyramid just to help you understand broad versus narrow. Now, the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are, the more broad the spectrum of activity. And broad versus narrow is not really a head count of how many organisms are covered by a specific antibiotic, but rather it is the propensity of causing collateral damage. So tier 1, which is considered pretty narrow, is essentially the urinary antibiotics, so nitrofurantoin and oral fosfomycin, as well as penicillin. So penicillin is considered the narrowest antibiotic when it comes to beta-lactams, and nitrofurantoin doesn't really go anywhere in the body other than the urine, so these agents are unlikely to cause collateral damage in the body. Slightly higher, so these are, tier 2 is still pretty narrow, but relative to tier 1, slightly broader, and these are first generation cephalosporins such as cefazolin, and also ampicillin and trimsulfa. So tier 2 is also pretty narrow, and these are good agents to de-escalate when we are using broad spectrum antibiotics. Now, I'm not going to be able to fit everything in there. So for example, I'm skipping second generation cephalosporin, so you can think of second generation between tier 2 and tier 3. And tier 3 includes third generation cephalosporin such as ceftriaxone, as well as ampicillin sulbactam and amoxicillin clavulanate. Now, these agents up to tier 3 do not have activity against ESBL producing agents. But when you get to the third tier, it's actually pretty broad spectrum. Now, tier 4, slightly more broad than tier 3. What's unique here is that ertapenem and gentamicin, they do have activity against ESBL producing agents. Ertapenem is a carbapenem that does not have activity against Pseudomonas, and gentamicin is an aminoglycoside that recently it is decided that it no longer has activity against Pseudomonas. So for that reason, because they don't have activity against Pseudomonas, they are placed in tier 4. Now from tier 5, this is where we get Pseudomonal activity. So everything in tier 5 has activity against Pseudomonas. And this is considered pretty broad. So unless you are trying to cover for Pseudomonas, you shouldn't really be using these agents if you have options. So cefepime, which is a 4th generation cephalosporin, ceftazidime, which is a 3rd generation cephalosporin, piperacillin tazobactam, fluoroquinolones such as ciprofloxacin, levofloxacin, and also the aminoglycoside tobramycin is pretty active against Pseudomonas, and amikacin is considered active against Pseudomonas in the urine only. Aztreonam is also a beta-lactam that's active against Pseudomonas. And tier 6 is actually more broad than tier 5. So these are pretty much carbapenems as well as ceftolozane tazobactam. These are not only active against Pseudomonas, but also active against multi-drug resistant Pseudomonas. So if you have Pseudomonas that's resistant against tier 5, tier 6 will still remain an option. So for that reason, they're considered more broad. And in the same sense, tier 7 is more broad than tier 6, because if you have pathogens that are resistant to tier 5 and 6, tier 7 may still be active. So you really want to reserve these. And in most hospitals, tier 7 and as well as sometimes some agents from tier 6, such as ceftolozane tazobactam, they're typically restricted. So you would need approval from the ID team to be able to use these agents, not only because you want to reserve them for resistant pathogen, but also these are pretty expensive. It's important to consider drug concentration in the urine and renal tissue when thinking about treatment of cystitis and pyelonephritis. So in this table, I'm showing you on average how much of each drug goes to the urine, and it's not that a specific number is a magic number, and certainly you don't need to memorize this number, but I just want to showcase that a couple of them have very poor concentrations in the urine. So clindamycin has about 10% in the urine, and moxifloxacin about 20%. So these two are actually considered pretty poor urinary concentrations. And one thing I want to note about nitrofurantoin, note that about 50% of nitrofurantoin goes to the urine, which might make you think that the other half stays in the blood, but because it's readily metabolized by all tissue, you're not going to have a significant concentration of nitrofurantoin in the blood. So anytime someone has bacteremia, nitrofurantoin is not really going to do much in the blood. Now, it's important to consider that nitrofurantoin and oral fosfomycin should not be used for treatment of pyelonephritis because they do not penetrate renal tissue. So it doesn't matter how much of it gets to the urine, but because the kidney tissue is where the infection in pyelonephritis is, you should avoid them in pyelonephritis, but they're fine for cystitis alone. Moxifloxacin and clindamycin, as I showed you, have very poor concentrations in the urine, so they should not be used for cystitis or pyelonephritis. And lastly, should avoid tetracyclines and tetracycline derivatives until more studies become available. So something like doxycycline may have sufficient concentration in the urine and some of these other tetracycline derivatives, but clinical studies are lacking, and two recent agents that came to the market, omadacycline and eravacycline, they were both tested in randomized clinical trials of patients with urinary tract infections, and both of them failed to achieve non-inferiority to the standard of care. So because two agents have already failed treatment, it's important to avoid this when possible until more studies become available. Now, here are the recommendations from the 2024 IDSA guidance on the treatment of antimicrobial resistant gram-negative infections. For uncomplicated cystitis specifically due to ESBL producing Enterobacterialis, the preferred regimens are nitrofurantoin or trim-sulfa. Alternative regimens include a single dose of aminoglycosides, oral fosfomycin only if it's E. coli, and fluoroquinolones such as ciprofloxacin or levofloxacin and carbapenems. And they specifically say to avoid doxycycline, amoxicillin clavulanate, cefepime, and cefamycins. For pyelonephritis or other complicated UTIs, again, due to ESBL producing Enterobacterialis, the preferred regimens include trim-sulfa, fluoroquinolones such as ciprofloxacin or levofloxacin, ertapenem or meropenem or imipenem, and alternatively once daily aminoglycosides. And this is not just a single dose, this is a full course of treatment. And again, they say to avoid nitrofurantoin because this is pyelonephritis. Oral fosfomycin should be avoided, as well as doxycycline, cefepime, and cefamycins. Let's take a look at duration of therapy for uncomplicated UTIs, which is essentially cystitis. And for this, we will go to 2010 IDSA guidelines for uncomplicated cystitis. And because that guideline is specifically in women, that's why we have, in women. So again, you can probably use similar recommendations in men. But you have to keep in mind whether the patient is likely to have prostatitis or not, because if they do, longer duration of therapy may be needed. And also you need to consider whether the agent you use has penetration into the prostate. But let's focus on women. So nitrofurantoin, 5 days of treatment. Fosfomycin is a single dose for oral fosfomycin, and pivmecillinam is for 3 days. For duration of therapy of complicated UTIs, which includes pyelonephritis, let's take a look at women. So this is from 2025 IDSA guidelines. So if you use fluoroquinolones, 5 to 7 days is sufficient. And they say for non-fluoroquinolones, 7 days of treatment. And of course, non-fluoroquinolones will be IV beta-lactams and trim-sulfa. Now, PO beta-lactams, there is limited evidence for using them for 7 days. So although the guidelines don't say specifically 14 days, many experts recommend to use 14 days of PO beta-lactams when it comes to treatment of complicated UTIs such as pyelonephritis. Now keep in mind that these total durations of treatment includes the empiric therapy. So even though the empiric therapy may have been a different agent, so if somebody, let's say, received 5 days of 5 days of, let's say, IV beta-lactam, and then they switch to PO beta-lactam, you will essentially subtract 5 from 14, and the difference would be, essentially oral beta-lactam to finish the course. Or if somebody had already received 5 days of fluoroquinolone and switching to PO beta-lactam, you may not need this 14 days. You might say that actually we are done with treatment. So, you may question why we're switching to PO beta-lactam. Now, for men, there's a couple of things to consider. If the patient has fever or bacteremia, it's likely that 7 days may not be enough. So 10 to 14 days is recommended. The same if the patient is suspected to have prostatitis. And, we do not cover prostatitis in this course. But again, for that, you will need longer duration of therapy than 7 days. Outside of these two things, patients will be treated similar to women. So if it's fluoroquinolones, 5 to 7 days, and non-fluoroquinolones, 7 days.
So let's take a look at the case study. So let's say CR is a 50-year-old woman with no significant past medical history and no known drug allergies, who is being treated empirically for pyelonephritis with ceftriaxone 1 gram IV every 24 hours. So let's say today is day 4 of treatment, and she's clinically well. Here's the results of the urine culture. So the organism is E. coli, and the susceptibility results have come back. So basically, R means resistant. So amoxicillin clavulanic acid is resistant. ampicillin sulbactam is resistant, cefpodoxime is susceptible, ceftriaxone is susceptible, ciprofloxacin is resistant, and trimsulfa is susceptible. So what would you use? So far it's been ceftriaxone. Ceftriaxone is IV, and at some point, if the patient is ready to go home, we can change this to PO. So ceftriaxone only is available as IV. So but first of all, you want something that's susceptible. You don't want to use something that's resistant. So augmentin, for example, is PO, but because it's resistant, we're not going to be able to use it. So from the things that are susceptible, trimsulfa is available PO, and so is cefpodoxime. Cefpodoxime is a third generation cephalosporin that's available as PO, so you have two options left. So between the two, the correct answer would be Bactrim, because PO beta-lactams don't get enough concentration in the urine. So if you do have options, PO beta-lactams should be your last option. So for example, if this patient happened to have sulfa allergy, then trimsulfa would not be an option, and then you can use cefpodoxime. But since this patient does not have sulfa allergy, we would go ahead and choose Bactrim, or trimsulfa would be the best option.
The last learning objective is to describe how over-the-counter products should be used in the treatment and prevention of urinary tract infection. So when it comes to over-the-counter products, a lot of people are interested in cranberry products, so juice or tablet. And this is essentially the idea behind this is that cranberry may inhibit adherence of uropathogens such as E. coli to urinary tract surface. If so, it may be able to prevent urinary tract infections. Now, historically, there's been limited clinical data on this. Back in 2013, JAMA released a clinical evidence synopsis. So essentially, the question they were asking, are cranberry products such as juice, tablets, capsules, and syrup associated with prevention of urinary tract infections compared with placebo or other treatments? And the conclusion at the time was that cranberry products are not associated with prevention of UTIs. However, lack of association of cranberry products with a reduced incidence of UTIs in clinical trials may be due to lack of participant adherence, lack of sufficient active ingredients in the cranberry product, or lack of sufficient statistical power. This actually led to an RCT that was published in JAMA in 2016. This is essentially was the effect of cranberry capsules on bacteriuria plus pyuria. So this was an objective way of measuring whether cranberry can prevent adherence of E. coli to the urinary tract. So they wanted to test the effect of 2 oral cranberry capsules once a day on presence of bacteriuria plus pyuria among women residing in nursing homes. And essentially, they found no statistically significant difference between placebo and cranberry. In fact, an editorial was published in JAMA, and essentially they said that the evidence is convincing that cranberry products should not be recommended as a medical intervention for the prevention of UTI. A person may, of course, choose to use cranberry juice or capsules for whatever reason she or he wishes. However, clinicians should not be promoting cranberry use by suggesting that there is proven or even possible benefit. Now, fast forward to 2023, there was a Cochrane review that essentially looked at everything that was published on cranberry. So essentially, cranberry products compared to placebo control or no treatment. And overall, they found that although it looks like it may reduce the risk of getting a UTI, there is significant heterogeneity. So you cannot conclude that this is evidence that cranberries reduce the rate of UTI. So I squared or Higgins statistic measures heterogeneity. So ideally we want there to be zero heterogeneity, but essentially less than 25% would be okay. This was 69% heterogeneity. With women with recurrent UTI, although the the results show reduced rate of UTI, but still significant heterogeneity. So that's why I have this in yellow. In elderly men and women in institutions, the study found no statistically significant difference between cranberry products and nothing. So essentially this crossed, the confidence interval crossed 1, so no significant difference. There is significant evidence to support that this may be beneficial in children. And that's beyond the scope of this topic. We are focusing on adults. For people who have issues with bladder emptying, such as patients with multiple sclerosis, no statistically significant difference. Now, in people who have susceptibility to a UTI due to an intervention, the evidence is clear that it may prevent UTI in those people. So no heterogeneity and statistically significant difference. No difference in pregnancy, and when it comes to safety, also no difference in adverse effects. So while cranberry products may not be as effective in most people, but also they're not causing adverse effects. So essentially, unless people are about to undergo a procedure that will put them at risk of getting a UTI, the evidence is clear that cranberry products are not going to work for the large majority of people out there. And lastly, for over-the-counter products, we have phenazopyridine. This is essentially a urinary analgesic to relieve the symptoms of UTI, such as pain, burning, urgency, and frequency. This has no antibiotic activity. So essentially, this is just to relieve the symptoms, and people should not take it up to 2 days. And essentially, because with proper treatment, symptoms should be gone by 2 days. So if someone has symptoms beyond 2 days, that could essentially indicate that the treatment is not working. So you don't want to mask that. So you want to make sure that people don't take it beyond 2 days. So if there are symptoms, they can go to their primary care provider or an urgent care to receive appropriate treatment. Now, some of the adverse effects of this could include headache, dizziness, or stomach cramp. And one thing that's important to communicate to patients as part of education is that it does have a dye that can turn the urine reddish. So that's important because, imagine someone who has pain or burning when peeing and suddenly see their pee turn red. They might, that might be alarming. That might make them think it's blood, for example. So you want to make sure that patients are aware of this. Okay, I'm here at my local CVS. Let's see where the pharmacy is. Okay, let's see. Here are the Azo products. There's one for urinary tract infection test. There's one for urinary tract, urinary pain relief. So the urinary pain relief has phenazopyridine in it.
That concludes this presentation.